Okay, so our last part that we're going to discuss with respect to the heart is how does our heart actually beat and how does our heart actually keep beating without us actually having to consciously think about it. So one of the first things we're going to take a look at though is what makes heart muscle distinct from the other types of muscles in our body. So of course most of us think, well, it's cardiac muscle, so it's only found in the heart. And yes, that is true, that's correct. But there's some other characteristics that make it very different from our other types of muscles, which of course are our skeletal muscles and our smooth muscles. So if we take a look at the appearance of our graphic here, so this is just our drawing of what heart muscle looks like, and then up here of course is our microscope image of cardiac muscle, so kind of gives us the view of both. When we're doing our heart dissection, one thing that we'll notice, particularly in the atria, when we cut the heart open and we look at the inside of the atria, we'll see this beautiful cardiac muscle that is branched in appearance. And when I say branched, it means like it almost looks like when you're chopping a tree and you kind of have those little branches of connecting parts of the tree, right? And so that branched appearance is very unique to cardiac muscle. We don't see that in any other type of muscle, okay? So if you even think of like chicken breast, that would be like skeletal muscle. And when you shred chicken breast, it's like stringy, okay? So it's striated, but it doesn't have that branched appearance, okay? So that's one of the defining characteristics, is that very special shape. Another one of the defining characteristics are intercalcated discs. So if you take a look here, these kind of black lines that are interspersed along the cardiac muscle, those intercalated discs are actually responsible for preserving the force of contraction as the electrical impulse travels through your heart. Because of course, as most of us probably know, your heart's rhythm is all about that electrical rhythm being transmitted from one part of the heart to the other to allow for contraction and relaxation and so on. So those intercalated discs prevent that impulse from weakening or degrading as it moves along the heart muscle tissue. So these muscle tissues are known as myogenic muscles, so that's just terminology there. And one of the other things that make it unique compared to, say, your skeletal muscles is that heart muscle beats without direct nervous system stimulation. So that doesn't mean that your brain's not involved, because your brain controls pretty much everything. So don't think of it as your brain not being involved. What it means is there's not a direct connection between your heart and your brain in terms of nerves, and but your brain still controls your heartbeat, and it's your medulla oblongata, which is your brainstem, okay? The back part there, which controls all of your autonomic functions so that you don't have to think about them, like breathing, digesting, and of course, your heart beating. So it doesn't mean that your brain isn't involved, because your medulla oblongata will send a message to certain tissues in your heart to get an electrical stimulus moving, but it doesn't have that direct nervous system stimulation, okay? So when we talk about that nervous system stimulation, one of the really important things that we have to know is the nodes. And when we talk about the term node, that basically is an umbrella term for a little bundle of tissue. And so if we take a look here, and again, we want to orient ourselves, where are we with respect to the heart? So this is our vena cava, of course. So we know that we're on our right side of the heart. So we have two nodes in our right atrium. So we're in our top chamber on our right side of the heart. So that's going to be our right atrium. And so we have two nodes there. So the first one is the sinoatrial node, also known as the SA node. And then the second one is the atrioventricular node, or the AV node, okay? So one thing I want you to notice when we look at the SA node is that you can see these arrows radiating out from that SA node to the other parts of the heart. So a couple of different things are happening here then. So one thing to remember, first of all, is the tempo of the heart is set by that sinoatrial node. So the sinoatrial node is known as our natural pacemaker, okay? It is the bundle of tissue that is responsible for setting and controlling the heart's tempo. So when we talked about our medulla oblongata, the medulla oblongata communicates with the SA node, and then the SA node will send electrical impulses out to the rest of the heart to keep our heart beating smoothly. Okay, so that's one important thing. So the next thing then that you can see is that the other node, the AV node, also acts as a pacemaker, but the SA node is the primary pacemaker. So what happens here then, kiddos, is when the impulse is sent out from our SA node, that does a couple of things. First of all, you'll notice the little arrows send an impulse to our AV node, okay? Secondly, you'll notice that we also get an impulse going to our left atrium, because you'll notice that our left atrium doesn't have nodes in there, right? Our left atrium is this bare chamber, okay, but it doesn't have any of those SA nodes or AV nodes or anything like that in there. So once our SA node sends out this communication, the left atria is going to contract because it's received the impulse. The right atria is going to contract, and also the electrical impulse is going to be received by our AV node. And I want you to think about AV node, what that stands for. AV is atrioventricular. So this is what controls the transmission of the impulse from the atria on the right side of the heart to the ventricles, okay? So that's why it has that term, the AV node. So then what I want you to notice as we go along here is the yellow also shows us that there's nerves along the septum, okay? And the nerves along the septum are called the bundle of His, and that's not anything to do with, you know, male versus female or otherwise. It basically is named after the scientist who discovered the node. So his name was Wilhelm His, okay? So that was his last name. So this center bundle of nerves in the septum is called the bundle of His. And of course, the whole purpose of the bundle of His is to get, it's connected to that AV node. So the whole purpose is to get that impulse from that AV node down the middle of the heart, so it then can be spread along the ventricles. So then the other thing you'll notice is you'll see that there's these other nerves along the side of each of the ventricles, and those are called the Purkinje fibers. And once the impulse has been transmitted from the septum, okay, so the bundle of His in the septum, to the Purkinje fibers that line the ventricles, then we have ventricular contraction, okay? So the tempo of the heart, we go from the medulla oblongata stimulates the SA node to send out an electrical impulse. The electrical impulse is transmitted to the left atrium, causing contraction, the right atrium causing contraction, and also to the AV node, which then transmits that impulse down the bundle of His, and then from there to the Purkinje fibers along the side of the ventricles, and that of course causes the ventricular systole. So make sure that you watch this cardiac cycle animation, okay, because it is very good in terms of giving an excellent visual of what's happening in terms of the cardiac cycle and that tempo of the heart, okay? So this graphic just kind of walks us through a little more specifically what the cardiac cycle is all about. So one thing I want you to notice is these Roman numerals here correspond with the Roman numerals on our diagram there, okay? So number one, the nerve signal reaches the SA node, right? And it passes its signal through the atria, causing atrial systole. Okay, so remember, the SA node, which is up here, will send its impulse to our AV node and to our left atrium as well, causing the atria to contract. The next thing that happens is the nerve signal, of course, arrives at that AV node, right? And then the AV node is going to transmit that nervous system impulse down that bundle of His, which is number 3 there. And then from the bundle of His, the nerve signal is going to continue up the Purkinje fibers, which of course line the wall of our ventricles, causing ventricular systole. Okay, so that is the cardiac cycle. So in a test situation, you need to know what your pacemakers are, where the signal originates, and how the signal travels through the heart to keep that cardiac cycle working. Now, another thing that's in our program of studies is the ECG printout here, okay? And we have that on a later slide, so I'm going to talk about that a little more specifically. But on this particular slide, the reason why it's here is because when a person does have an ECG done, this printout here, that is actually a mapping of the cardiac cycle of the individual having the ECG. Okay, so doctors can look at that and make sure that everything is looking normal in terms of the heartbeat. So we talked about the nodes, particularly the SA node being the natural pacemaker of the heart, but of course we also have artificial pacemakers. So if an individual's cardiac cycle is not performing properly, and that can be for a number of different reasons. It can be an issue with the nodes. Usually that's what it is, but it can be different issues. What can be done in terms of technology is an implantation device called a pacemaker. So there's pacemakers alone, and then there's another type of device called an ICD, which actually combines a pacemaker and the defibrillator. Okay, so I know you guys have seen like the paddles, right, where they deliver the electric shock to reset the heart's tempo or the heart's electrical rhythm. And so that we can have just a pacemaker, or we can have a dual device depending on what the individual's needs are. So basically, though, one of the biggest misconceptions about a pacemaker is that it's inserted right in the heart, and it's actually not. So you can see in the microscope, or sorry, the X-ray image here, you can see the pacemaker, and you'll notice that it's not actually embedded right in the heart. And you can see that we have these like wires, right, that are kind of coming out, those electrodes that are kind of coming out of that pacemaker. And so if we look at our diagram here with our dual chamber pacemaker, you'll notice that it is implanted kind of just under the left clavicle, or the left shoulder blade, and then, or sorry, collarbone, not shoulder blade. And then you can see that basically the electrodes, the wires, are fed through the subclavian vein, and then down the vena cava, superior vena cava, and then into the heart itself. Okay, so what the pacemaker does then is it artificially simulates the action of the nodes that are in the right atrium so that the rest of the heart can continue beating properly. So we would call that an artificial pacemaker. Now, another video that I really want you to make sure you watch, and I will show this one in class too, is the lub-dub video, because that shows us a really good graphic and most importantly, the auditory of what's happening when we hear that heartbeat and we hear that lub-dub sound, okay? So the lub is considered to be like the first heart sound when you're listening to a heart through a stethoscope. And this actually is from the AV valves closing. So it's a misconception that when you listen to a heart that it's actually the ventricles contracting and the contraction of the heart that's making the sound. It's actually not. It's the opening and closing of the different types of valves. So the lub is the closing of the AV valves. Okay, so remember those are your cuspid valves. And this happens during ventricular systole. And if you think about that, that kind of makes sense, because when the ventricles are contracting, if your cuspid valves were open, your ventricles would contract and the blood would just gush right back up into the atria. So when the ventricles are contracting, the whole point is to push the blood out of the heart, right? And so we want those AV valves closed tightly. That's where those chordae tendineae come in to pull the valves shut closed and taut, so that there's enough blood pressure to not only move the blood out, but it also prevents that backflow. Okay, so that's where that first sound comes from. So I'm sure you can probably predict where the dub sound comes from. The dub sound comes from the closing of those semilunar valves. So remember, we have that aortic valve and that pulmonary semilunar valve. And so when those ones close, that's what's making that second sound, that dub sound. So this happens at the end of ventricular systole, when we don't have any more blood passing through the semilunar valves and there isn't any more pressure to keep them open. Okay, so watch that video. It's a really good representation, visual and auditory, of the heart sounds. So another little video on ECGs, but most of you kind of, I think, already know what ECGs are, but really what it is it's to determine whether or not the cardiac cycle, the electrical rhythm of an individual's heart is working properly. So the electrical activity of the heart can be measured using an electrocardiogram or an ECG, and the machine that records the actual data is called an electrocardiograph. So this thing here, the actual printout, is called an ECG tracing. So essentially what happens is the machine is brought over to the patient, and then the nurse or the doctor or whatever will put a number of different electrodes on different parts of the body. So you'll notice there's some on the arms, there's some on the chest, and you'll notice there's some wires kind of running down here because there's some that are attached to the ankles as well. And then the machine is set to run, and then what it does is it produces this ECG tracing. And so what doctors will do is they'll look for abnormalities in the cardiac cycle to try and determine what's going on with an individual's heart. So one of the things that we do need to know is what exactly does this particular section of an ECG tell us? So this is just obviously one cardiac cycle here, okay? This image, this is one full cardiac cycle. So what do we have to know? We kind of have to know what the PQRST actually means. Now, sometimes kids are like, you know, what do those letters actually stand for something specific? And the answer to that is no. It's believed that the scientist that kind of mapped this out was a fan of René Descartes, who was a mathematician, and I mean, this might be urban legend, I don't know. But anyway, mathematician and a philosopher, but he was kind of the one that came up with, Descartes that is, kind of came up with on, like, you know, graphs in mathematics, that, you know, a point on a graph is P. And so then, I don't know, we kind of just continued. We're going to start with P, Q, R, S, T. So doesn't really mean anything in terms of, you know, do those letters actually, are they an acronym for something, or did they stand for something? Not that scientific. Okay, but what do the parts actually mean? So the P wave, which is this section right here, okay, that indicates the contraction of the atria. Remember, your atria are relatively thin-walled, they're smaller, so we don't get a huge, big contraction, because the thing the atria have to do is they have to contract enough to move the blood from themselves into the ventricular chambers, right? So that's what the P wave represents. Now, this section here, then of course we have that bit of a pause while the electrical impulse is being transmitted, right? So then we have this QRS complex, and the QRS complex is the ventricular systole. So if you think about it, it kind of makes sense, because we have this huge peak as we go up to that R. So the QRS complex, that's what the whole part is called there, records the contraction of the ventricles. Lastly, again, we have another pause here, of course, as the electrical impulse continues to be transmitted. And then lastly, we have the T wave, and the T wave indicates the recovery of the ventricles. So when the ventricles relax and they start to refill in order for the whole cardiac cycle to start over again. All right. Now, how do scientists know, or how do doctors know rather, when there's something wrong? If there is something wrong in terms of there's an impending heart attack, there's damaged heart tissue, our nodes aren't working properly to naturally set the pace of our heart, then we'll see abnormal peaks. Now, it's beyond scope for us to actually look at those and analyze those, but doctors will look at it and they'll be able to see if there's any abnormalities. And then wherever the abnormality is, then that kind of gives them an indication of what part of the heart is compromised. So for example, if the P wave is abnormal, then they know that there's something going on with the atrium, and quite often they'll look to that right atrium to see what's going on with the nodes, and if the nodes are actually working properly. So our last thing that we'll take a look at is cardiac output. And cardiac output refers to the amount of blood that flows from each side of the heart per minute. And the reference standard is 5 liters per minute. Now, obviously, that's going to vary a little bit from individual to individual, and that's why we say the reference standard is 5 liters per minute. And when we calculate cardiac output, this is a super popular, question on exams, because it's one of the very few calculations that we have in Biology 20. But in any case, it's really a simple calculation. So there's two factors that impact cardiac output. The first one is the stroke volume, and that's literally the amount or the volume of blood that is pumped each time the heart actually beats. So those, we have that big ventricular systole, how much blood is actually being moved out of the heart in terms of volume. And the second part that combines to calculate cardiac output is your heart rate. And the heart rate is the number of times the heart beats per minute. Typically, what you're told to do when you're taking your heart rate is to use your wrist instead of your neck because it's more accurate. And you typically will count the number of beats for 10 seconds and then multiply that by 6. Okay, so typically that's the way that is calculated. So how do we actually calculate cardiac output? Q, it's believed that Q, again, doesn't stand for anything specific, but probably comes from the QRS complex, right? Stroke volume is equal to, cardiac output is equal to, because Q stands for cardiac output, stroke volume times heart rate. So that's pretty straightforward. So in other words, Tom's heart has a stroke volume of X number of mils in heartbeat, so calculate. So you just have to multiply it, okay? Not complicated. So you just have to multiply stroke volume by heart rate, and that gives you your cardiac output. So our last little speech bubble here is exercise and Q, exercise and stroke volume, and we can also talk about exercise and resting heart rate. So from a standpoint of cardiovascular fitness, we can think about what type of individual is going to have a high stroke volume, low resting heart rate, and typically that's associated with people that do a lot of cardiovascular exercise. So if you think of like swimmers, marathon runners, okay, anybody that regularly pursues these types of exercises that have a high cardiovascular demand, they typically have lower resting heart rates, okay, and they typically have higher stroke volumes. And if you think about it, people that do those kinds of exercises, they're working a muscle, they're working their heart. And so as a person exercises, their heart actually becomes stronger, their heart becomes more efficient, so the heart doesn't have to beat as often to move the necessary volume of blood with each ventricular contraction.